for the last decade or so in the Carolina, Virginia chapter, and chapters do all of the hard work. So I thank you all for your participation and for inviting me to speak with all of you this evening. And as Rita said, we're going to talk about the challenges and management of the critically ill patients that are boarding in the emergency department. Let's see if it's going to let me advance the slides. And I have no financial disclosures. Now, in the emergency department, we take care of everyone. And at times, it can seem very chaotic. And our goal and our focus is how do we bring order to the chaos so that we can take appropriate care of the patients. Now, a typical day in the emergency department looks like this. Now, from the outside, if you're not in medicine, this may look very chaotic, but for those of us who are in medicine, we know that this is a very organized team. Clearly pre-COVID, because there's not everybody in full PPE, but they're the team at the bedside is taking off handoff. You have students and learners at the back of the room, but everyone is participating in their roles. Unfortunately, this is what the EDs around the country look like. You've got patients stacked everywhere. We have more patients than we have places to put them or staff to see them. And during the last 2 years, it was not uncommon that during times our EDs became ICU. And while this is certainly not ideal, I think we've all risen to the challenge of COVID. And fortunately, at the moment, I don't think anybody's emergency departments are functioning as COVID ICUs, but we'll see, the numbers are going back up. But let's start with what comes into the emergency department. And there's a realistic mix of the patients that we see. There's the cohort of patients that are actively trying to die, that need immediate resuscitation because they've either come in as a code or they're about ready to code unless you actively and the team immediately takes care of them. Then there's the next group of patients that has the high potential to die, that if you don't address them relatively quickly, they will succumb to whatever their illness or injury is. Then there's the third group is a group that is not very ill, but ill enough to seek care. And if they don't get appropriate and timely attention, they may progress to more serious illness such as septic shock or hemorrhagic shock, depending on what their problem is. Then there's the fourth group. When I leave that term convenience in there, but I think anyone in this day and age knows that the ED is not convenient for anything, with wait times that can last hours, if not sometimes a day or more in the emergency department. But there are many patients around this country and in the world who have no other access to care. And depending on where you practice, will depend on what percentage of these patients you see in your emergency department. If you're in a high volume, high acuity inner city hospital, you're going to have a much higher percentage of patients that are actively trying to die when they come in. And also at the other end, a high level of patients that have nowhere else to go for care. Let's start with Dr. Saffer, one of the founders of FCCM, our second president, and known also as the father of resuscitation. And almost 50 years ago, he coined the term the continuum of care, and that is really the focus of this presentation. Now, he focused mostly and suggested that most of the care of these acutely ill patients is in the critical care unit, be it the MICU, the SICU, the CCU. But we know now, and for the last probably 20 years, you can see those green lines that I've added. There's a significant amount of resuscitation, pre-ICU, that occurs in the ED and sometimes on the ward. And then patients are leaving the ICU in a much sicker condition than they were 15 or 20 years ago, going out to the ward and needing continued ongoing care. And then in that post-hospital state, we have to worry about illness and also PICS. But that's a talk for another day. So let's start off with the terminology. Now, most people in many places in the literature, you will see this is referred to as inpatient boarding. But that's a bit of a misnomer because the ED is traditionally an outpatient setting, and these patients certainly are boarding, but they're not boarding in an inpatient setting. The appropriate term is probably more ED crowding. Thought there'd been another piece of that slide, but apparently not. So why is there a problem? And that's where we need to start with is what is the initial problem and where can we focus our efforts? And this slide is a little bit older, but I'll explain why I use this. This is looking at number of hospitals and emergency departments on the left-hand side. Right-hand side is number of emergency department visits, and then the years along the x-axis. And as you can see, starting about 30 years ago, the number of hospitals in total declined, the number of emergency departments also declined, yet the number of visits to the emergency department have dramatically increased. I choose this slide because it ends with, it's very clear, and it ends in 2004. And as you heard, I trained in my emergency medicine and critical care at the Medical College of Pennsylvania, which was the start of emergency medicine. It was the first 3-year program of emergency medicine in the country, graduating a first class in 1972. And MCP, unfortunately, for a variety of political and financial reasons, closed in 2004. So this is my nod to my alma mater. It's important to know that in 1975, there was about 1.5 million hospital beds in the United States. As of 2015, that number is less than 1 million total beds. And yet, this past year, the numbers visiting the emergency department, over 130 million visits to the ERs across the United States. So the numbers of patients coming in have dramatically increased. The number of beds and places to see them have dramatically decreased. As I just mentioned, the volume is increasing. It's more than up 25% in the last decade, or more than 60% in the last 20 years. The number of patients presenting to the emergency department who require acute resuscitation and critical care has tripled in the last decade. Admissions to the ICUs have increased by 80%, and the ED length of stay has dramatically increased. Had been on average about 6 hours to now sometimes it can be days in length. And this looks at the critical care burden, ED critical care in hours on the left-hand side and ED visits on the right-hand side, ED departments on the right-hand side. And as you can see, the amount of time delivering critical care in the emergency department has exploded in the last decade, and this is over a decade ago. Now, one of those reasons is the number of transfers. It's not surprising when you have less hospitals and less emergency departments and less places to put patients, you have to send patients somewhere else. And many hospitals, maybe the hospitals that you work in, have eliminated their inpatient obstetric care, inpatient pediatrics, and inpatient mental health. These are 3 big cohorts of patients that need to be transferred many times to high-level academic or specialty hospitals. And you can see as the time has progressed in years, the number of transfers from emergency departments to either emergency departments or inpatient beds has dramatically increased in the last 5-6 years, where over 14,000 patients are estimated to need transfer every day, a third of those being patients that need mental health. And if you're in a small volume community hospital, you may be the only ED provider, or it may be one MD and an APP, and not only do you need to care for all of the patients that you have, you need to get on the phone typically. You don't necessarily have case managers and social workers and other assistants to help you find a bed for these patients that need additional care. When you break it down, you see that about 3% or so of patients need transfer, and the higher volume emergency departments and hospitals, minimal patients are being transferred out, and those are typically going to be maybe mental health, maybe burn patients, but in general, the high volume academic centers are able to care for all types of patients. But when you get down to that less than 20,000 volume emergency department, a small rural community or inner city community, sometimes even, high percentage of those patients need to be transferred because they are unable to care for those patients on an inpatient setting. Another challenge is this concept of hospital disequilibrium, where the demand of the patients who need to be admitted doesn't match the capacity of the inpatient beds. And it's a little bit of a misnomer. It's not uncommon that you have more patients needing admission. The challenge really is the timing. And what I mean by that is, as you can see here, at all hours of the day and night, patients come into the emergency department. We're open 24/7, 365 days a year. And patients come in and need to be admitted. But when you think about it, the majority of patients who get discharged from the hospital are doing them during the traditional so-called banker's hours, 9 to 5, 9 to 6. And so this has, you start off every day with a backlog of patients that are waiting to be admitted to the hospital and waiting for a bed, waiting for these patients to be discharged home. And we're going to go through that. So for those of you who work in the inpatient side, you know there's many delays of trying to get a patient out of the hospital. It can be transportation. Either you're waiting for an ambulance to transport them to an LTAC or a SNF, or perhaps even a home, or you're waiting for their family to get off of work. They may need equipment. During sometime oxygen. During last summer, there was some challenges in Florida and around the world. There was this low supply of oxygen because of the lack of rain. They were having difficulty making small oxygen tanks. Patients need to wait for medications. In centers that have residents and house staff, getting those discharge orders and notes written so that the patients can be discharged, that their medicine can be got, that is another delay. Sometimes patients just refuse to leave the hospital, and because they're either not well enough or they've got nowhere to go. There are many stories. When I was in medical school in Newark, New Jersey, we had an individual who had spent over a year in the hospital and refused to leave, and they were unable to discharge him. And many systems have patients that are like that. There may be financial issues of where this patient can go, and then there's also the family challenges. And all these things add up to a wait time of trying to get patients who are appropriate for discharge out of the hospital. And FAAEM looked at the data and found that when the hospital occupancy rate hits about 80% is when difficulties occur in both admitting patients to the hospital and then getting timely throughput of the hospital and getting patients discharged. And as you can see on the right-hand slide, the higher the hospital occupancy, the higher the time to expected transfer delay in the hospital of getting a patient out of the emergency department or even out of the ICU to the floor. So when your hospital reaches about 100% occupancy, the average expected transfer delay is about 24 hours. So a full day delay to get these patients beds where they need to be. And in the ICU, you may have heard the term ICU discharge delay. In the ICU, you're receiving patients from the ED, transfers from other hospitals or transfers from the ward, that patients who have decompensated, patients from the operating room. And then there's that term, the ideal ICU length of stay, when the patients who need the care and critical care are receiving that timely care. And then there comes a time where the patient is stabilized and is ready for transfer to a floor bed or an LTAC or wherever. But there is that time frame that they may be delayed in going elsewhere. And it's that transfer delay that also adds to the backup throughout the entire hospital system. And in those transfer delays, there's problems with acuity. You know, we have staffing challenges. Everyone is familiar with that, I'm sure. And you now have patients who don't need the higher level of care are waiting to go to the floor. So they may be assigned to a nurse who's already on 1-to-1 or 1-to-2, and they're like, oh, it's a stabilized patient. They're going to the floor, and they don't need as much care. But the nurse or the care provider is not necessarily neglecting the patient, but they have so much time to care for the critically ill patient, they may not be able to get antibiotics or other medications on time to that individual who is now on floor status because of the nursing staffing issues. What nurse, when there's a problem with those patients, which team is covering the patients? Who do you call? Is it the ICU team who may have changed? Or is it the floor team who has yet to see them on the floor? Who do you call for these patients? And then these patients are still subjected to all the typical ICU stressors. noise level, alarms, lights on, frequent interruptions, adding to that post-intensive care syndrome potential. And he also looked at, FAAEM looked at the transfer delay in hours to in-hospital risk of needing to be readmitted to the ICU or death. And as you can see, the longer it takes to be discharged out of the ICU, the higher the likelihood that the patient may need to bounce back to the ICU or has an increased risk of death in the hospital. And this is Bagshaw's study that came out right at before the data from pandemic. You can see here that blue line that glows across over the 5-year time frame from 2012 to 2016 was a relatively steady occupancy rate in the hospital. But when you look at avoidable time, you see here that as it progressed in 2015 and 2016, there was a much longer time to getting to the appropriate bed, and that's because the occupancy rate of the hospital had dramatically increased. And this was a Canadian study, the same study, and he looked at the data and found, and my go to webinars on it, but you can see here the number of, in the 5 years, the number of days added up to over 20,000 hospital days, and the number of percent was 20% of the hospital time. And then when you look at cost, it was over $10 million in cost, and almost 20% of the ICU cost was spent on patients who were not necessarily needing to be in the ICU that had no other place to go. So significant time and cost. Now this study, if you have the opportunity and you're interested further in this data, this Morley in PLOS One, the references there for you to pull, go through, and you will see this slide throughout this talk, where they go through the summary of different things. They look at the problems of input, throughput, and output, causes of ED crowding, and then solutions. So you will see that. And so I would recommend that if you're further interested or want further data, this would be the study to start with, because it has all the links that are already in there. Now, what about the impact? We've heard about the why, but what's the importance of this? Well, this is a very common slogan that's been around for years. What happens in Vegas stays in Vegas. Although we know the reality is that what happens in Vegas lives on the internet forever. And prior to about 20 years ago, most individuals in the House of Medicine felt that whatever happened in the emergency department didn't really matter for the patients, and that when they got to the ICU, that you would just fix it and take care of it, and whatever the ED didn't matter, and the ICU could fix it all. I'm sure you're all familiar with the early goal-directed therapy study of Dr. Rivers and company out of Henry Ford that was published in 2001, November. And this study demonstrated the importance of emergency medicine. Now, I know over the years there's been some debate and some difficulties and some challenges with the studies, and I'm not here to review that. That's a discussion for another day. But what this study highlighted was the fact that appropriate early resuscitation makes a difference. And that is, I think, the takeaway point that you need to focus on, is that at this point, the House of Medicine suddenly realized that the emergency department, what happens there really does make a difference and affects patients' long-term morbidity and mortality. And so we need to really start care as soon as patients enter the system, including in the pre-hospital space. And along the same time frame was the discussion of this emergency department overcrowding and the impact on the critically ill. This is a study that came out of Cooper and showed that they looked at about 90% hospital capacity. Now, I don't know about all of you, but other than the really beginning of COVID, unless you were in a hotspot, that's about the only time that my hospital has not been at full 90+ to 100+% capacity. And this data is from 15 years ago, plus years ago. And the amount of critical care time that they were delivering in the emergency department was over 150 days worth of critical care. And they focused and they highlighted the delay of therapy in those that were subtly ill. The patients that were in shock and acutely trying to die had timely and appropriate care, but those patients that may not have looked as ill to begin with, but were smoldering and had that potential for bad outcome, may not have had initial therapy as quickly as need be because of all of the difficulties of boarding and the challenges. But this is a new study, came out just this year, but I'll highlight to you, and this study is out of the UK, is that 6-hour time frame, and this is from time of arrival, not time of waiting for a bed, but time from showing up in the emergency department to getting a bed. Over and over in all of these studies, you will see that 6-hour time frame is a critical time frame, because once you pass 6 hours in the emergency department, all comers increase in mortality. The longer you spend in the emergency department, the higher the likelihood you have to have a bad outcome, regardless of why you're in the emergency department. When they looked at numbers needed to treat, this is that UK study. In that 6 to 8 hour time frame, it was 82, I believe. It's covered here. And then in that 8 to 12 hour time frame, it was number needed to harm was 1 in 82 patients, and then in the 8 to 12 hour time frame, number needed to harm is 1 in 72. You work at a high volume center that's 80,000, 100,000 ED patients every year or higher. It doesn't take long to hit that 1 in 72 waiting for 12 hours and the number needed to harm. This was from Project Impact, looking at over 50,000 patients. And what they found, delay in 6 hours or more versus non-delay, significant percentage of increase of hospital and ICU mortality and length of stay. This was a smaller study, similar findings, that 6 hour time frame, but I want you to look at the numbers. Patients who immediately went up, there was about 400 patients, as you can see. About a third of them were immediately transferred to the appropriate ICU. About 2/3 of them had a delay in admission. Those that immediately went to the ICU, 2/3 of them survived, 1/3 did not. But those that had that 6 hour or more delay, half of those patients died. That's a significant number of patients. And they showed here, as you would expect, the longer you're in the emergency department waiting to get to the ICU, the higher the likelihood of mortality, regardless of what your cause is. This is just another study showing a similar thing, boarding time to in-hospital mortality, and this was out of Long Island. And also length of stay in the hospital also increased. So even though these patients survived, increasing morbidity for the patients, increasing in cost for the hospital system. And this is looking at time to ED to the ICU, and they broke it down a little bit more than just that under 6 hours. Under 6 hours, that's 6 to 24 hours and greater than 24 hours. And not surprising again, the longer you're in the emergency department, the higher the likelihood of mortality. And these are patients going to the ICU, and it showed delay in admission was an independent risk factor for mortality. And there seems to be a break point at that 6 hours and then again at more than a day. This was specific in the trauma patients. This was out of Wake Forest, looking at patients who had an ED average length of stay of 3 hours. They eliminated patients who immediately went to the operating room or to the ICU, and they also eliminated patients that were discharged. So this was in the cohort of patients, of trauma patients that were admitted to the hospital but did not immediately go to theater. And they found the average length of stay was about 3 hours, and that mortality for these inpatients increased with each hour in the emergency department. And it was that hour 4 to 5, if they were still in the emergency department, they had an increased risk at that point. And it seemed to be directly linked to the number of consultants. So here you see that ED length of stay, the longer the length of stay, the higher the likelihood of mortality. And the more consultants, the more likelihood that that patient may have a bad outcome, even in the emergency department. And they didn't go into explain why, but I think it may be that each consultant is worried about their system. Ortho's worried about whatever fracture there is, neurosurgery is worried about the spine and the brain. And there may or may not have had attending, either trauma attending or emergency department oversight, keeping an eye on the entire patient. But it does show that there is a concern that these patients need to be evaluated rapidly and transferred. This was in critical care medicine a few years ago. Matthews out of New York City looked at patients who were rapidly admitted in the 4-hour time frame, that those who were delayed had about an average of 12 hours. And because of this, they created what was known as an ICU bed czar. Now, in this day and age, they may not pick that term, and I don't know if they still use that term, but this was the term that they used. And this was an individual who they had someone 24/7 who was responsible for knowing the location of all of and status of all the beds in the house, so that the patients could be appropriately sent to an ICU for appropriate level care. Patients could be transferred as needed, but this was an individual who knew where all of the beds and staff were located to help facilitate care. And they found, not surprisingly, the longer that they were boarding predicted the likelihood of developing organ dysfunction and dying. Multiple different adverse outcomes. I've listed a couple of the studies here. Studies have shown longer time on ventilator, poor stroke recovery, longer length of stay in both the ICU and the hospital, and then the increased morbidity and increased mortality that we've already discussed. One of the morbidities this was out of Penn, looking at blunt trauma patients who required emergent intubation and if they had an associated head injury and they were over the age of 50. Now, I'm just reporting the data. It's unfortunate that a lot of trauma data seems to break at that age 50 point. We don't do as well as our younger cohorts. But if you had a head injury and you were over the age of 50 and required emergency intubation in the ED and you spent any significant time in the ED, you were 20% more likely to develop pneumonia compared to your younger cohorts or those that did not have head injury. And Sun looked at the consequences for the entire system. This was out of California. This data is now about 10 years old, so just increased the amount of money that's there, but they found that there was a 5% increase odds of death. So that amounted to about 300 patients a year. Hospital length of stay was over 6,000 patient days and had 1% increased cost. And in 2013 money, it was $17 million. I can't imagine with the rate of inflation that we have today, what it would equate to today. But it was not just developing problems, but also getting therapy to patients. Pelton looked at giving antibiotics from the time of order to the time of delivery, and the more volume and more boarding of patients in the emergency department, not surprising, the longer it took for antibiotics to be delivered. And there's a 10% increase for each volume increase in the emergency department. Another study, very similar, looking at the antimicrobial lead time, patients who had higher comorbidities, and they had an antimicrobial lead time of greater than 1 hour. They had a higher 28-day mortality. And when they looked at their data, more than half of their patients, it took them more than 1.3 hours to get the antibiotics from the time of order to the time of delivery. And step one metric aside, we know that in patients with septic shock, the sooner you get the antibiotics into them, the evidence shows within an hour these patients do better. So here we have on all comers 1.3, so we need to do something. And this just looked at the suspected time delay. Patients with shock did get their antibiotics sooner, but there still was a delay in time. And that 6-hour time frame, not just in spending time in the ED, the 6-hour time in delay to get your antibiotics increase these patients' mortality. But before we leave impact, we have to focus on not just the patients. We need to spend just a moment talking about the healthcare workers. And boarding is one of the leading causes of stress and burnout. And I know this slide I don't think is in your packet. This is a really interesting study. It's in critical care medicine in 2021. And this group had the fortuitous insight, though they probably didn't realize it at the time, of doing a burnout evaluation, and this is from the Netherlands, in the fall of 2019. And they had gathered their data. And then what happened in the winter of 2020? COVID came. So they had just gathered data in fall of 19, and then they regathered and repolled the same individuals in the spring. And I believe this was April to June of 2020 during peak COVID. Number one, both pre and post-COVID, leading cause of moral distress and burnout, providing suboptimal care due to insufficient funding, time, or staff. That's burnout and boarding in a nutshell. A very nice study to see. And then here's that summary of consequences again, and just looking at patient effects, staff effects, system effects, and the studies that correlate with that. But unfortunately, we do need to mention COVID. I know we'd like to all stop talking about COVID, but there were difficulties, as we know, at least in the United States, unless you were in Seattle or New York City, and a couple other hot spots. The acuity in the emergency departments went up, but the volume went dramatically down early on in that March and April of 2020. You see that pictured here. 2019 in the light blue, 2020 in the dark blue, in that March to April timeframe, 42% drop in patients coming to the emergency department. But you would expect that that would make boarding less of an issue. Well, it didn't. There's over 6 million patients, looking at the ED volume and the length of stay on the right-hand side, pre-COVID in the blue, post-COVID or COVID in the dashed lines. As you can see here, in March, April, and May, dramatic drop in the numbers of patients coming to the emergency department. But when you look at the boarding is higher despite the fact that there's less overall volume. And the length of stay increased by 10%. So where is the problem? We talk a little bit about in the hospital and in the ICU. I use this slide so that in the emergency department, for those of you who are not actively working in the emergency department, there are multiple points along the way that can be focused on that are breakpoints, just like in the ICU. Everyone gets interrupted. Patients are becoming unstable. You need to evaluate them. You get many distractions. But from the time the patient arrives to the ED to the time that they are transferred to the ICU, there are multiple competing challenges. Generally, early on, we know which patients are going to need to be going to the ICU or potentially the OR. The problem is there are many different things that we have to do to get them there. And this is a nice little roadmap that you can use for trying to evaluate where some of the challenges in your system are. So what are the possible solutions? Several years ago, FCCM and ACEP combined a joint task force to look at possible solutions with the goal of mitigating strategies for the boarding of critically ill patients, and it was published simultaneously in both CCM and Annals of Emergency Medicine in 2020. And they focused on 3 things: ED solutions, hospital solutions, and the RCUs, the resuscitative care units, formerly known as the ED ICU. Some of the ED solutions that have been shown to be successful is altering your staffing, putting a doc or an APP in triage along with the nursing so patients can be assessed simultaneously, labs can be ordered, imaging can be ordered. Some patients may be able to be seen and treated from triage. Others can have their care delivered, and then the care provider can decide, oh, this patient is sicker than they look, we need to find them a bed in the back. Registration should be simultaneous and not having patients evaluated, triaged, then registered, and then seen. And then case management. If you have the ability to have case management or social workers or both in the emergency department, that can help with some of these challenging patients of getting their medications, getting them equipment so that they are able to go home or back to whatever care facility they came from instead of needing to be admitted, or helping facilitate admissions. And then creating some specialty areas such as a fast track area, an observation unit, or an ED ICU, or a similar resuscitative care unit. Some hospital solutions that were recommended is that discharge planning, if you don't do this already, should be implemented essentially when the patient comes in. They should be assessed for, do we think this patient will be going home in the next 24 hours? And if so, what are the things that this individual is going to need? There needs to be a bed leader, to use the term from New York, a bed czar who is aware of all of the beds in the hospital and has the authority to mandate where patients will be going, that they can't be blocked by whoever may be blocking the patients in your facility. Discharge lounges, we'll come back to that in a minute. And then developing ride share programs for individuals who don't have a ride home because their families are working or their families are not available to come get them or their families don't have transportation. Some places are using Uber and Lyft and other types of ride share programs to take stable patients home to be met by their family members or their caregivers. Some places have instituted these discharge lounges, whereas an area that is in theory comfortable, they are Jerry chairs, I'm not quite sure how comfortable it is, but a place that patients can go to wait while they're waiting for their families, their rides, medication, equipment, whatever it may be, so that they can be discharged home safely, but at the same time that the bed that they were in has the ability to be cleaned and turned over so that the next patient can be brought into them. This is especially important with COVID, and if you have COVID rooms that need to then be deconned with your Trudy or whatever other that you're using. Our Trudy takes on average about 3 hours still to decon a room. Now this is hot off the presses. This won't be in your slide deck. This came out, I believe, in August of this month, is the ability to directly discharge patients from the ICU. Now, back in Philadelphia, when I ran an ICU, many times we did discharge patients directly from the ICU because we were challenged even 20 years ago with beds on the floor. But this looked at, is it safe in stable patients? Are you able to discharge them home? And the answer is, with the appropriate resources, yes. I would say that if you're discharging patients directly to home, you do probably need to get some help from your hospitalist and making sure your case managers have everything set up so that they have follow-up care set up. Because from the ICU, we don't routinely practice this. We're not routinely writing home medications for patients and setting up their outpatient PT and follow-up. So you really do need to have a good care team that knows how the appropriate steps to discharge these patients. But it's been shown to be a safe process and maybe something that a system needs to look at. And this was just that summary slide of the solutions, looking at the input, the throughput, and the output. So the last bit we're going to focus on, the ED ICU. This concept came about because many of the patients who come into the critical care don't spend a long period of time here. And when you look at the top diagnosis going into critical care units across the country, it's nonspecific chest pain, syncope, TIA, take up a significant percentage of the numbers, but they don't spend very long in the hospital, as you can see there. And many patients routinely are discharged in a day or less. And so that was one of the goals of looking at these observation units and also these ED ICUs as people who need short resuscitation and turnaround, not going to a critical care bed in a patient who may need 3, 4, 5 days in the ICU. And so hospital systems and emergency departments and ICUs across the country created these types of systems. And an ED ICU, some of them do have full capability to do everything that is done in an ICU that is not located in or next to the emergency department. advanced hemodynamics, they can do RRT, they can place ECMO. Probably one of the best examples is the Michigan MC CCC unit in Detroit. And here's their data led by Kyle Gunnarsson, who's a friend and currently the ED emergency medicine representative on council. And his group looked at creating this ED ICU and how the flow of these patients would go through the emergency department. And what they found, is that they looked at it for 3 reasons. 1, the cost of the patients. 2, outcomes. They saw that the outcomes in people who were boarding were worse. And trying to decrease the boarding. And they found that they decreased their ICU admissions by 13%. That's pretty significant. And here's the data that was published in JAMA. The dashed blue line is when they went go live in the spring of 2015. And not only did they decrease the amount of time getting patients to the ICU, they decreased the morbidity of all patients going to ICUs across the system. Now, the goal of the resuscitative care unit is just like every other ICU, right care right now when the patient needs it. It needs a dedicated team to provide continued critical care, and typically it's going to involve a novel space. These are the 4 main models of the ED-ICU. There's the RCUs, the ED-ICU we talked about, and then we'll go through these other models. The ICU observation unit is just like any other observation unit, is meant to be a short-term location where you stabilize the patient, but you cannot escalate to things such as RRT or ECMO, but you are able to maintain pressors, A-lines, and continue observation. Rapid diagnosis units are those that relatively spring up to offload during surges. Think of all of the COVID units that popped up around the country and around the world during the surges of COVID. And they can also be used to triage patients during times of disaster, be it man-made or environmental. And this is just a picture of the rapid novel units. You can go to the FCCM website and look at Neil Halpern and others had a very nice write-up on how to develop these novel ICUs. And also the write-up on how to reconfigure other spaces to become ICUs. And those are worth a look if you're not familiar with it, but I think after COVID, many of us are very familiar with that. But there's also the ED critical care team. And this, I think, is probably one of the easier types to implement, though you do still need some staff. It's going to provide direct patient care, but there's not necessarily a dedicated space. You don't need to spend millions of dollars building an ED ICU, building an ED observation unit. Most beds in most emergency departments already are monitored, and you can hopefully connect them to telemonitoring, so patients can either be telemonitored by your ICU that's doing telemonitoring, or a directed team can round on these patients that are boarding in the ED. And looking here at the early intervention, you can see the hospital length of stay. This is the early intervention team. This just came out recently, and this was a temporary team that goes into place between the hours of, I believe it's like noon and 10 o'clock at night. So it's not present 24/7, but when the ED is becoming overwhelmed and there's more critical patients, this team is in place to focus specifically on those critical patients that need to be admitted, don't have a bed to go to, and they care for these critically ill patients while the rest of the ED continues to care for the incoming patients, and showed that that they had similar outcomes. And not surprising that the higher the SOFA score of these patients and the higher the acuity in the emergency department at that time, the more likelihood they were to involve these ED ICU consultants. I mentioned telemonitoring. Kadar and his group looked at using telemonitoring in the ED and changed the mortality significantly. Had a mortality previously of these boarding patients 20%, dropped it down to 5%. Level of care was changed. In the patients that were being monitored, a third of them were able, because they had continued ongoing care, to be downgraded to either step down or floor level care. Length of stay of the hospital decreased by almost 2 days. Yet boarding, and this seems a little counterintuitive initially, that boarding length time doubled. But because these patients were receiving ongoing care, they were able to then resuscitate them appropriately and then take them to a less acute bed in the hospital. So another option to consider. And I know that's a lot of information in a very short time, but I think it's important to understand when you're going to look at your own system, you need to understand where the problems are, what the impact is, and what are some ideas that you can focus on that you can then take all this information back to your administrators, to your directors, to try and assist the flow of the system. And we started with Dr. Saffer, and we're going to end with Dr. Saffer, a great quote from about 30 years ago. The most sophisticated intensive care often becomes unnecessary, expensive terminal care when the pre-ICU system fails. So what are the recommendations? You need to identify the problems. Where do the problems exist? Why do the problems exist? It's not going to be just in the ED. It is really a system-wide problem, and it's going to require mitigation strategies throughout the entire system. And that for the critical care patients that are boarding in the overcrowded ED, if you can come up with some way to have a dedicated team, plus minus a dedicated space, this will hopefully improve the overall care of all patients, decrease the levels of stress on your staff, and make our patients' outcomes improve, and hopefully keep our staff from going completely stressed out. And with that, I thank you, and I'm happy to take any questions. And I think if I stop my show, or Rita, if you want to take over, or I'm not sure if how I give this back to you. But I thank you for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Bailey, for a really great talk. At this time, if any of our audience have questions, y'all can type in your question in the question box, and we're happy to share them with Dr. Bailey and get her thoughts on these. I did want to start with a few questions that I was actually jotting down as you were going through some of the presentation. For the RCU teams that you mentioned being a dedicated team, at my current hospital, a lot of times we will have ICU boarders, but it's actually the MICU team that's following them. They've been formally admitted, but they're currently being taken care of in the ED until they actually get a physical bed. So what are your thoughts on the MICU team managing versus an actual RCU team that's at the bedside from a provider perspective? And then I had some follow-up questions regarding nursing.
So first thing I would say is that you are ahead of the game, because it is not uncommon for critically ill patients in the emergency department to be in no man's land because they're not admitted to an ICU, and the ICUs understandably are full, and they don't necessarily have time to come down and see. And the argument is, well, they may not come to my ICU because they may go to the CCU or the SICU or wherever else. And so you've got a critically ill patient in the emergency department where the ED attending is rotating, some places every 8 hours, sometimes every 12 hours. So the person coming back the next day is not necessarily the same ED attending versus typically, at least in the ICU, you're usually on for a week at a time. So there's really not a lot of continuing care going on. So I think you're a step ahead, that your MICU team is coming down and helping manage these patients. I think it depends on your system, and it depends on the redundancy in the system and who is able to come down and who has, nobody has extra hands, right? But who has someone who is knowledgeable, because the interns are great and we need them, but the interns really don't have the experience or the knowledge, just like we have so many new nurses who've come straight from nursing school into their first job. And, you know, in years ago, you could never get a job in an ED or an ICU straight out of nursing school. But now many of our nurses are straight out of training and they don't have that experience to recognize that subtly sick patient. So I think it depends on the system. I'm glad and I'm thrilled that someone is managing these patients, because in many emergency departments across the country, no one is managing these patients. It's left to the ED attending who comes on to eyeball the patient and try and find a bed in some ICU for that patient while they're managing all the other patients that are coming into the emergency department. So I think it's whatever works for your system. And it doesn't need to be a full team, but it certainly needs someone who has experience, be it an attending, be it an experienced APP, you know, PA, or a nurse practitioner in critical care, someone who knows critical care and can identify what's going on. I don't know if that answers your question or not, but at least you've got someone who's managing these patients. For that, I'm thrilled. And so you had a nursing question as well, I believe?
Yeah, so I think my follow-up question was actually touched on it a little bit. So what are strategies to ensure adequate nurse competency, as well as appropriate nurse staffing once you get to that patient, that you're not just stabilizing in the trauma bay or just stabilizing in your like the resuscitation room and then transferring out? Now this patient is actually in the ED. So how do you ensure that the patient who's on multiple drips, et cetera, who's going to be down there for 24 hours or longer, the nurse actually has the protected ratio to provide the appropriate care to the patient?
Well, that is the challenge, right? Because in the ED, there is no protected ratio, versus in the ICU, the documentation has been around forever, and the evidence has been around forever, 1-to-1, 1-to-2 for not quite as critically ill. But that documentation, if it exists in the emergency department, I've not seen it. If anybody has it, I'd be thrilled if you email it to me. But we know that our ED nurses are beyond stressed, because not only do they have the boarding patients, whether they're, you know, they've broken their leg and they're being admitted to ortho and they're relatively stable, but they still need pain medication and care, or they have the septic shock patient who's waiting to go to the ICU, and then the next, you know, motor vehicle crash comes in that they need to care for as well. And that's, you know, I think boarding and burnout are really tied together, because it's a huge burden and a huge stress. As to nursing competencies, ideally everybody who's working in the ED and the ICUs is critically care trained and has their certification. That's not the reality, especially in many of the community hospitals, who are challenged with trying to get anybody to work in the rural, some of the rural areas, or some of the inner city areas as well. Same difficulty is trying to get staffing. But ideally, everyone should have the training, and that's one of the things that you need to discuss with your nurse managers of the ED and the ICU, is making sure that there is ongoing education, so that our nurses and all of the staff feel comfortable caring for these patients. And how do you manage an A line? How do you set up an A line? How do you troubleshoot it? How do you set up your drips if you're not familiar with it? What happens if the pump fails? How do you set up your pressors? How do you manage that? Do you know where to get the information if the pump wipes out and you don't have any of the preset you know, mics per kilo per minute that's preloaded in many of the pumps these days? So I think it's vital, you know, for both our patients' safety and our staff well-being, is that there has to be ongoing education. And I think a lot of that, you know, during COVID, when we were so challenged, a lot of that went by the wayside, because we needed to care for the patients, because we were all just overwhelmed. But now that, you know, we're in this persistent state of, you know, COVID, I think that we can try and we need to get back to focusing on education and care of the staff. and making sure that the staff have what they need, because it's, you know, it goes hand in hand with the boarding.
Again, if any of our audience have questions, please feel free to type it into the box and we'll be happy to take them. Dr. Bailey, I have another question for you. So the reality is many of us are boarding patients in the ED, ICU patients in the ED. What are some, I guess, criteria regarding who gets that first ICU bed that opens up? Is it acuity? Is it certain disease states that can be managed? Is it certain medications? What's a good way to build that triage system that actually helps with throughput, even ED to ICU?
So I think that also depends a little bit on the capabilities of your system. Obviously, the most unstable patient is the one that you want out of the emergency department to the ICU, where hopefully they will have one-to-one nursing care, because the most unstable patient requires resources, and that is going to require more resources in the emergency department. So initially, I would start with the most unstable patient. And then any of the patients, you know, the trauma in general, our trauma ICUs somehow seem to find a way. In general, our trauma patients spend less time than most in the emergency department. And I think the trauma centers are very good at trying to stabilize the patients and get them out of the emergency department. But others, you know, like CNS processes, you know, acute bleeds in the head, if nurses are not in and the ED maybe not be comfortable managing some of these very acutely ill patients, and the longer term management, long-term ventilator management, you know, everybody, you know, emergency medicine is trained in how to start the ventilator and some initial skills to use to adjust the ventilator to help assist with the patient based on, you know, waveforms in the blood gas. But that longer term management after the first hour or two or three is emergency medicine currently is not really focused on that. You know, I was fortunate in my training was that we spent 9 months of our 3 years in an ICU. So we had which is where I developed my interest. And so, but most emergency medicine programs are not that heavy in critical care focus, at least at this time. So I think it would start with the highest acuity, most complex patient would be the first one that I would remove from the emergency department to a more stable location of the ICU so that they can have focused care. And then the specialty patients, you know, would be the order that I would send them. But again, it really is. This is why it takes. It's not just, you know, what the ED wants to do. This involves the ICU directors. It involves administration, because to do this appropriately and to care for patients appropriately, it does require staff, which requires funding. And in the long run, if we're appropriately staffed and can care for these patients, then people don't get burned out and people don't leave. Because it's really a self-fulfilling prophecy. The more boarding there is, the less staffing that there is, the more people that are going to burn out, the more people that are going to leave the system and maybe leave healthcare. I mean, it is estimated that by 2030, that's not that far away, the world is going to be 6 million nurses short. And what I saw that in that article was that to ensure attempting to meet that need, that every nursing school in the world would need to increase their current class by, I think it was 10 or 15% starting now. I don't see broad calls out for people to go into nursing. We desperately need all levels of critical care, but our critical care nurses at the bedside and our ED nurses really are the safety net. They're the ones who care for the patients. They're the ones who are the first in general to notice that there's a problem, this patient isn't responding. We need to do everything that we can to encourage both new people going into nursing and to save the nurses that we have. save the rest of us as well, but we really need to do something. And hopefully these are some mitigation strategies that can help your system care for the patients and improve the flow. But it's not just in the ED. It's from, the time the patients come to the door to how they get out of the door, housekeeping, cleaning, environmental cleaning the rooms, making sure that medications are ready to go with patients, oxygen tanks are ready to go home with patients, transport is set up, all of these things. It is an intricate dance.
Absolutely, and a pretty complex one.
Yes.
Thank you very, very, very much for all your insights. This has been a wonderful talk with lots of learning points and provoking thoughts for how we can apply some of these principles in our own institutions. We thank you again for your time, and we thank all our audience for joining tonight. We again have our bite-sized lecture in November, as well as our chapter business meeting, and we will be sending out more information regarding that. Dr. Bailey, it's been a pleasure having you.
Well, thank you so much. My pleasure. I'm always, the chapters are great, and they really are a great place to start and continue your career, and the overall society as a whole really appreciates and values the support of the chapters.
Thank you so much. And our audience is saying this was excellent. Thank you.
So good. I'm glad you enjoyed. It's hard, when there's no feedback, hard to say. So if anyone has any questions, my email was there. Please feel free to send me. And I think pretty much almost everything was in there, other than those 1 or 2 slides that I pointed out.
Thank you very, very much. And we hope that everyone has a great night. Thank you.
Have a good night.
Yeah.